Good evening to all respected chairpersons and the organizing team of AKI 2021. Thank you for the opportunity of talking to you on renal preservation in acute kidney injury. We know that 1 in 5 adults develop AKI during hospital stay, and AKI can affect up to 50% of critically ill, most frequent causes being sepsis, hypovolemia, nephrotoxic agents, and major surgery. The mortality continues to be very high. Even survivors of only mild or short episodes of AKI have a greater risk of developing CKD, end-stage renal disease, or severe cardiovascular complications in later life. We all know that no specific pharmacological interventions are available to treat AKI. So it's crucial that we avoid preventive strategy, that we employ preventive strategies to avoid AKI. We are all aware about the KDIGO AKI care bundles. More uniform standard of care has been established. There is a critical need for identifying high-risk patients early to prevent AKI. We have plenty of biomarkers. It's been found that the TIM2 and the IGF-BP7 are able to predict impending development of severe AKI in stages 2 and 3. And these new biomarkers may help us to detect kidney injury early before significant kidney damage occurs. In a study of 358 patients on AKI at the Stanley Medical College, we found that sepsis with skin and soft tissue infection is a predominant source causing AKI. So what are the renal preservation strategies in septic AKI? We'll talk about renal hemodynamics and pressure support. Global renal blood flow does not diminish in sepsis, but AKI still develops. So this is believed to be because of constriction of the renal efferent arteriole and dilatation of the efferent arteriole. So this has been proposed to explain a fall in intraglomerular pressure leading to loss of GFR. Intrarenal blood flow redistribution, driving blood away from medulla and increased shunt capillaries also contribute. And there is endothelial injury and thrombosis as a result of this microcirculatory dysfunction. The renal perfusion pressures are held widely. However, in hypertension, the autoregulatory curve shifts to the right. And in shock, the autoregulatory curve can flatten such that autoregulation is lost. So the loss of autoregulation causes shock, causing blood flow, which becomes dependent on the pressure-flow relationship such that renal perfusion pressure is dictated by the MAP and the venous outflow pressures. So are there any individual MAP goals? More than 65 is recommended. However, it may vary from patient to patient. Higher BP levels above 80 is associated with less AKI and RRT needs. So it is underlined that more individualized pressure and perfusion targets as well as organ failure prevention strategies are important. What are the therapeutic options to optimize renal hemodynamics? Which one to choose? We have vasopressin in 4 trials. No effect of vasopressin on the 28-day mortality. It, however, reduced the requirement of RRT. However, there was more digital ischemia but fewer arrhythmias. A2 was tried in the ethos trial, angiotensin 2. Here, it was compared with ICU patients with AKI treated with RRT at initiation and a placebo group. The 28-day survival and the MAP response was higher. So the rate of liberation of RRT was greater in the A2 group. So patients with vasodilatory shock and AKI requiring RRT may preferentially benefit from A2. Compared with conventional norepinephrine, which we all use in the ICU, there is an improved MAP in septic shock patients treated with NE, but did not translate to improved renal outcomes. Angiotensin 2, faster liberation from RRT in the angiotensin group in patients with septic shock. However, by the VANISH, VAST, and the VANCS trials, vasopressin, by causing preferential constriction of efferent glomerular arteriole, resulting in increased GFR, was superior to A2 as well as norepinephrine. Coming to fluid therapy, the fluid infusion, excess fluids are always a problem. Excess fluids, when exceeding the capacity of lymphatic drainage in the microcirculation, cause interstitial edema. In the kidney, interstitial edema increases subcapsular and intracapsular pressure, leading to reduction in the forward renal blood flow, reduction in the venous return and lymphatic drainage, ultimately causing tissue hypoxia and AKI, analogous to the compartment syndrome that happens elsewhere. So in septic AKI and in multiple studies postoperatively, there has been a positive fluid balance between connection between positive fluid balance and mortality. The renal blood flow is high in septic AKI. Fluids can lead to increased workload on the kidneys, and hyperchloremia caused by chloride-rich infusion can further worsen the picture. Intra-abdominal hypertension could also contribute. So this is the classic randomized trial that compared restricted fluid resuscitation versus standard care protocol in 151 septic patients in the ICU. So restricting resuscitation fluid successfully reduced volumes of resuscitation fluid compared with standard protocols in adult ICU patients with septic shock. So there seems to be a benefit with fluid restriction. This is the RIFS trial that showed septic patients in the ICU again assigned to restrictive fluid strategy or the usual care. The restrictive resuscitation strategy successfully reduced amount of IV fluid administered to patients with severe sepsis and septic shock. No increase in mortality, organ failure, or adverse events were noted. Which is the best fluid again? Crystalloids accepted as the first-line IV fluid therapy in sepsis in AKI. High-quality studies showed that low chloride balanced crystalloid like Ringers associated with lower AKI risk than chloride-rich 0.9% saline. This is the basics randomized trial. This showed that among critically ill patients requiring fluid challenges, treatment with a balanced solution versus normal saline did not significantly reduce the 90-day mortality. So we have evidences for both. Mitochondrial dysfunction-induced renal inflammation is one of the main, is also an added pathogenic mechanism in the causation of AKI, and probably could lead to a therapeutic target in future. Remote ischemic preconditioning, which is several short cycles of limb ischemia caused by inflation of BP cuff. The mechanism is incompletely understood. This is being mainly evaluated in cardiovascular surgery and after contrast administration. However, a Cochrane Library systematic review of 28 RCTs of all surgery types did not show any benefit of remote ischemic preconditioning on development of postoperative AKI. And larger studies and meta-analysis are not consistent in demonstrating a preventive effect of remote ischemic preconditioning for AKI. Another drug that's been promising is the dexmedetomidine, which is a promising alpha-2 agonist used for perioperative sedation, blocks sympathetic mediated stress response and vasoconstriction, facilitates earlier extubation, and reduces post-op delirium. It ameliorates the kidney IRI and the inflammatory response and hypoxemia-induced apoptosis in the proximal convoluted tubule cells in the kidney. So these could be further targets of emerging chemotherapy pharmacotherapies like recombinant alkaline phosphatase CD28 receptor antagonist, alpha melanocortin stimulating hormone agonists, iron chelators, levosimendan, the bone morphogenic protein receptor agonist, hepatocyte growth factor, mesenchymal stem cells, etc. Artificial intelligence and deep learning, which could use integrated patient information with a real-time risk, combined with stratification into high risk and low risk, and could contribute, could prove very valuable. And the concept of a kidney telemetry system is certainly attractive in the future. So for preventive AKI, the following lessons can be learned: early diagnosis and recognition of high-risk patients, prevention, removing toxins and optimizing the hemodynamics, organ failure often functional despite maintained organ perfusion and cellular integrity, vasopressor therapy and maintenance of MAP is organ protective, pressure goals to be better defined and should be individualized. Rapid fluid therapy is important, however, overhydration may worsen organ function. Balanced crystalloids are the best choice of fluid resuscitation. Inflammatory processes and mitochondrial dysfunction may be new targets for development of novel therapeutic strategies. Let us hope By employing all these techniques, we could move towards 0 by 25 initiative as early as possible. Thank you very much for your patient listening.